Hello, everyone, and welcome to our July Coast to Coast Prostate Cancer Support Group meeting presented by Prostate Cancer Foundation BC and our support initiative, Prostate Cancer Support Canada. For those of you who don't know me, my name is Rochelle, and I will be moderating this meeting today with Maya, my colleague in our support services. First off, I just want to thank you all again for joining us today and attending this meeting. And before we get started with our guest speaker, I'll just go over our housekeeping items. So mics will be muted during Dr. Stewart's presentation, but please feel free to send any questions via the chat should something come up during his presentation. Alternatively, you can also raise your hand using the raise your hand function on Zoom, which depending on which device you're joining us from and which version of Zoom you have, will be found under either participant or reactions on your Zoom toolbar. When you press raise your hand, I'll see that you have a question and then call on you to unmute yourself to ask your question. Please note that support group meetings, as always, are strictly confidential, excuse me, and any personal information that is shared here today should not be shared outside of this group. The first half of this meeting will be recorded to share with others who are not able to attend today, but the recording will be shut off following Dr. Stewart's presentation to encourage free and open discussion, as well as to protect the privacy of all of our participants. A reminder as well that our facilitators, moderators, and participants today are not to provide medical advice. In other words, it's encouraged for participants to speak about their experiences with treatment, but a participant should not suggest or tell another participant to seek a certain treatment, medication, or medical procedure. As always, the opinions and information that are shared at these meetings do not replace the advice of a medical professional. Following the presentation portion of the meeting, there will be time for a Q&A period. If you would like to ask a question, please raise your hand using the raise your hand function. Oh, I already said all that. Oops, sorry guys. Depending on how long the Q&A runs, we should have time for small group discussions and support group meetings in the breakout rooms that you chose when you registered for this meeting. If you decide you'd like to visit a different breakout room, please feel free to let me know and I can move you. And now I will pass it over to Maya, who will introduce Dr. Stewart.
Thank you, Rochelle. So Dr. David Stewart trained in medical oncology in the Department of Developmental Therapeutics at MD Anderson Cancer Center in Houston, Texas, from 1976 to 1978. He was on staff at MD Anderson from 1978 to 1980, then in Ottawa from 1980 to 2003, and back at MD Anderson in the Department of Thoracic / Head and Neck Medical Oncology from 2003 to 2011. He returned to Ottawa in 2011 and served as head of the Division of Medical Oncology in Ottawa from 2011 to 2019. His areas of interest have included, among others, resistance mechanisms to anti-cancer agents and resistance modulation, pharmacology and pharmacogenetics of platinums and other anti-cancer agents, new drug development and predictive biomarkers in lung cancer, the negative impact of dysfunctional regulation and clinic trial designs on the rate of clinical research progress, and the huge cost of this clinical research dysfunction in terms of increased healthcare costs and in terms of lives prematurely lost. He has published more than 340 peer-reviewed publications. He's also published several op-eds in the lay press dealing predominantly with patient access to care, including an opinion piece published in the Ottawa Citizen just in June. In April of 2022, he also published a book intended for patients and the general public entitled A Short Primer on Why Cancer Still Sucks, which is available through Amazon Books or his website, which is whycancerstillsucks.com. So without further ado, I will leave the floor to Dr. Stewart.
Okay, so can everybody hear me? First of all, I'd like to thank Rochelle and Maya for inviting me to talk today. I'll give you a first warning. My kids refer to me as a techno-peasant. So if anything goes wrong with the whole session, that's because of my limitations with technology. I did give a very similar presentation to this as to the Canadian Cancer Support Network a couple of weeks ago, so that if anybody saw that, you'll notice a lot of overlap. But it's because of the importance that I give to access to therapy. And I won't be covering much about prostate cancer in the talk, but happy to answer any questions about that after completion of the talk. Oh, I just have to figure out which computer I have to hit to get the slides to go down or up.
No problem.
Okay. Okay, I thought I finally got to move here. Okay, so here's my financial disclosures. Something that's always important for anybody in academics to do is to say where we got our money from so that people can then identify what may be contributing to our biases. So 98.5% of my income comes from government, 1.3% from consulting for drug companies, 0.1% from a patent that I co-own and I test for gene therapy, 0.1% from completing insurance forms for patients, and I will be collecting in royalties at some point on the book that I published. So here's a book, and as Mayor said, if you'd like to ever buy a copy of it, you can get it online through it from my website, whycancerstillsucks.com, or through Amazon Books. I plan to give a free copy of the book to all Canadian members of Parliament, all Canadian senators and Ontario MPPs, and other selected Canadian and US opinion leaders. So the way I'll just go very briefly into the chapters. I won't go into detail on any of them except the first one, just give you an idea of some of the things it talks about. So the first one is dealing with the deluge. Why is cancer so common? And as most of you are aware, cancer will affect about 49% of all Canadian males and 45% of all Canadian females at some point. So it's very, very, very common. And it causes 25 to 30% of deaths in Canada. So it is by far our most common cause of death in Canada. And the reason that it's more likely to occur as you get older is that because of all the cell divisions in your body. So each of us has an average of about 37 trillion cells in our body. About 100 billion of those cells divide every day. And there's an average of 3 mutations per cell division. So in other words, each of us has an average of about 300 billion new mutations occurring in our body every day. So the incredible thing is that we all don't develop cancer at a much earlier age than that happens. But most of the other mutations are either repaired or they are unimportant. But a few of them can contribute to the eventual development of cancer. And the more mutations you have, the higher the risk that you'll develop cancer, and the more mutations just from becoming one day older or from exposure to factors that increase the amount of mutations and increase the damage. So factors that can increase risk, including anything that increases mutations. So smoking, sun exposure, radiation exposure, drinking even a small amount of alcohol, processed foods, inflammation from any cause, being overweight, eating beef, veal, or lamb, although chicken, pork, fish, and pork do not appear to carry an increased risk. And diets that are poor in fresh fruits and vegetables also are associated with an increased risk of developing cancer. So also anything that increases the number of cell divisions in the body. So high calorie intake or being overweight increases with increased risk of cancer. And also hormonal factors that will drive cell division. So if you eat a lot, have high calorie diet, you're producing more insulin and more insulin-like growth factor. That increases cell divisions and increases the risk of developing cancer. And also family history is important. So if you've got a very strong family history, that increases risk. And in some cases, it's because of inheritance of genes that you just don't repair DNA damage quite as well as other members of the other population. So the second chapter, I won't go into even that much detail in most of the chapters until we get to the access part of the book. But the second one is lurking in the depths about cancer screening. And it discusses why screening does not work better than it does, and why it works much better in high-risk people than in low-risk people, and why it often does not add very much benefit in people that are at low risk of developing cancer. Chapter number 3 is how cancer makes people feel so sick, all the symptoms that can be caused by cancer. Chapter 4 is about cancer surgery. Why can some cancers be operated on but not others? And if it is completely removed by surgery, why may it still recur in the future? So this chapter goes into that, and also how giving chemotherapy or radiation after some types of surgery may improve the chance of cure. Chapter 5 is about radiotherapy or radiation treatment, how it can help cure some cancers, or how it will improve symptoms of cancers that cannot be cured but may be causing symptoms, how radiation can help those. Chapter 6 is about chemotherapy and targeted therapies and hormonal therapies. How these can actually make people feel much better if they make a cancer shrink, and also how they can meaningfully prolong life expectancy if they do make a cancer shrink. Chapter 7 is about the immune system, how the immune system protects us from cancer, why it fails, and how modern immunotherapy treatments are revolutionizing our treatment of cancer. Chapter 8 is on how cancer therapies cause side effects, the side effects that they cause, how they do it, and some of the things we can do about those side effects. Chapter 9 is on complementary and alternative therapies. Why are they alternative? And the simple reason is because they're not proven to be of benefit. So all the things that are claimed for them, there's no proof to substantiate what's claimed. That does not mean that none of them will ever work or that they don't work. It's just that the claims that are made just have not been substantiated. And so many of them actually do not work. But there is a possibility that some at some point could in the future be shown to be a benefit. But so far, they have not been shown to work. Chapter 10 is oncology myths and legends, what the public and oncologists believe that may not be true, and how that can mislead us and slow us down. Then we get into the access parts that most of this talk will be about. So chapters 11 to 14, they deal with issues around drug development, drug approval, drug costs and funding, and also access to just diagnostic and therapy for cancer. So chapter 11 is mired in the mud, the high cost of caution, how in the process of being very careful, we actually slow ourselves down very markedly. Chapter 12 is some of the things that slow us down, the barriers to progress. And this is called speed bumps on the Autobahn. If any of you have driven on the Autobahn in Germany, it has large sections of unlimited speed limit. So if your car will go 250 kilometers an hour, you can drive 250 kilometers an hour. And yet it has one of the lowest traffic fatality rates in Europe because of very smart regulation. And so there's a lot of good things that happen there. But then if you put a whole bunch of speed bumps on the Autobahn, then you can imagine that that would slow things down markedly. Chapter 13 is if I had $1 million, the explosion of cancer therapy costs. Why are they so expensive? Chapter 14 is ours is better than yours, the battle of the healthcare systems. And here I draw on my experience in both the American system, where I spent a total of 12 and a half years working, and the Canadian system, where I've spent 30 years working, and the pros and cons of each, because both have major strengths and both have major weaknesses. Chapter 15 is Say Not the Struggle, Not a Fail, the future of cancer care, how things are going to change radically in the fairly near future, how they are changing very, very rapidly. And as long as we keep investing in research, things are going to keep on improving very, very rapidly. So going back now to chapter 11, Mired in the Mud, this deals with issues with drug discovery and development. And this is from a paper that I published a few years ago, where we reviewed about 27 different clinical trials of drugs that had a statistically significant impact on improving meaningful life expectancy in patients with metastatic cancers. And we looked at, we took how much the life was prolonged and the average by those therapies, and then multiplied that by the number of people dying worldwide of that cancer in a year to calculate the number of life years lost per year of delay in getting the drugs approved. One life year is one person being alive 1 year. And so the average across these drugs was 80,000 life years lost for every year of delay, or 1 life year lost for every 7 minutes delay in getting the drug approved. So it takes an average of 12 years to bring a cancer drug from discovery to marketing if randomized clinical trials are required. If you do not need the randomized clinical trial because the drug is so effective that it's approved as a breakthrough therapy designation, just being highly effective in small numbers of patients, then some of these can be brought to market in 4 to 6 years. So this is very good, but for most drugs, it takes far longer than that. So because of the length of time it takes to bring drugs from discovery to approval, so across these 27 examples, it was an average of 1 million life years lost per drug between the time that the drug was discovered and the drug was approved. So this is, again, worldwide figures. So we thought that this information would be very interesting to people, and a lot of people would be very concerned about it. So when we submitted the paper for publication, we were actually quite surprised because the first 8 journals that we submitted it to all turned it down before journal number 9 finally agreed to accept it. And to get a study published, it has to undergo peer review. So other researchers who look at it and say what the strengths and weaknesses are and whether it's important enough to be published. So a few researchers of these peer reviewers said, well, the losses are so huge that this cannot possibly be true. This is just far too big for it to be true. But anybody could have access to exactly the same public data that we used to do these calculations, and this is very, very true. Other people say it makes no difference if we knew about this, because these are problems we can't fix anyway. So if we can't fix the problems, then we don't need to know about the problem. Other people said, well, it makes no difference. So since so few people worldwide would be able to afford these expensive drugs, even if they're available, so this really isn't all that important if the drugs are delayed, just because a few people in rich countries could happen to access them. We also submitted several op-eds to lay papers on this, and they all turned it down until finally the Globe and Mail finally accepted it. But again, to my surprise, nobody commented it. I received no feedback from anybody on this large loss of life. So many years ago, Joseph Stalin said, if one man dies, it's a tragedy. When thousands die, it's statistics. And this is a problem. We've become numb to this problem, to the simple reality that these delays in getting these effective new drugs to patients comes with major consequences. So chapter 12 is the things that slow things down. And one of the important things is that every speed bump that's there is there for a very, very good reason. It was put there because of a major problem that happened in the past. So in clinical research, there have been major problems with ethics violations, human rights violations, safety violations, and violations in data integrity. So regulation is absolutely essential. But the thousands of speed bumps on the research highway, they markedly slow progress. And this increases research costs. And because it costs so much more to comply with all this regulation, that it means when the drugs are eventually marketed, they must be much more expensive because the companies have to recoup the cost of bringing the drug to market, or else they won't keep on investing in the drugs. And also because of the delays in getting the drugs approved, there are thousands of life years lost because of these delays in approval. So there's been extremely little attempt to quantify the cost of these regulations and to come up with a more efficient, less costly alternatives. Because if you have something that's necessary, but is causing major problems, then you look at the details to figure out how you can do the same thing, but with far fewer problems, and that just has not been done. So chapter 12 is a call to action on the problems that these things arise, that they lead to, and what we can do about them. And we know for sure, we've got unequivocal proof now that if we pay attention, we can solve this. How do we know? Well, with COVID, a total out of Canadians who developed COVID, 1.1% of Canadians developing COVID died from it. Among Canadians who develop cancer, 37% of people who develop cancer in Canada will die from it. So from January 2020 until June 2022, 41,600 Canadians died from COVID, while 200,000 died from cancer. When it came to developing COVID vaccines, it only took 1 year because of everybody paying a great deal of attention to smoothing these speed bumps to get everything done fast. Before this, the fastest vaccine ever developed was for mumps, and that took 4 years, but the average is 7 to 12 years to develop a vaccine. And here we are at 12 years for anti-cancer drugs. So if it only takes 1 year to develop a COVID vaccine, then cancer drug development should be much faster, because it's exactly the same factors that limit the speed of developing cancer drugs as COVID vaccines. It's exactly the same group of regulations that are governing it. Now, I don't think we'll ever be able to get a cancer drug down to developing in 1 year, but it would be very realistic to get it down to 3 or 4 years with huge savings of lives. So my feeling is that the regulatory framework must change. And this has to be an international initiative, because the regulations that govern this, they are harmonized across all countries, so that one country can use data from another country, so that countries need to work together to fix this problem. So the next chapter is, if I had $1 million, the explosion of cancer therapy costs. So here's what's happening with new cancer drugs. So there's been a rapid increase in the number of effective new cancer drugs that are available. So this is data from the European Medicines Agency, just showing that 1 year to the next, the number of effective new cancer drugs being approved is going up rapidly. And that's because of investment in cancer research. In 2012, in the United States, a new cancer drug, it cost an average of $90,000 to treat a patient for a year with one of these new anti-cancer drugs. With the new anti-cancer drugs that came along in 2016 to 2017, this number had doubled to about $180,000 per year. So very, very, very expensive. So why is it going up so rapidly? And one of the major reasons that the drug development costs are rising much faster than inflation because of all those speed bumps in drug development. So in 1962, it took an average of $4 million to bring a drug from discovery to approval. By 2013, that had risen to $2.9 billion. And those costs, they have to be recouped after the drug is marketed, because no company, any company would go bankrupt if they spent this much in drug development and then could not make that money back once they started selling the drug. The other thing is that because of these very high costs, only large companies can compete. And so it forces small companies out of the competition, and this directly reduces competition, and that contributes to higher prices. Also, because it takes 12 years on average to develop a drug, and a patent is only good for 20 years, it means that after that 12 years of development, a company has to recoup the cost within the 8 years remaining in their patent protection, so the prices have to be very, very high. And also there's a very high failure rate. Of cancer drugs entering clinical trials, 92 to 97% of them fail. Only 3 to 8% of them are ever marketed. And the ones that succeed have to pay the cost of the ones that fail. Again, if a company could not recoup the cost of their failures, then no sane company would keep on investing with this high failure rate. There's also been the problem of personalization therapies. I shouldn't say a problem. Because of personalization, therapies work much better now than they did a few years ago in areas that we can personalize them. So 20 or 30 years ago, if I treated lung cancer patients with chemotherapy, I'd use the same drugs for all my lung cancer patients. Now, if my patient is in the 1% of patients that has a ROS1 fusion gene, then it still takes the same amount of money to develop the drug for that 1% of the patients. But now the costs have to be recouped from a much, much smaller market. So the only way to do this is for the prices to be much higher. In this chapter, we also discuss what's called distortion of market forces. These are games that drug companies play that they don't have to play, and that we can get to change, because these also contribute to rising prices. If we only do this, it'll have minimal impact, but this is also important in addressing this. And then there's this dirty word, profits. The pharmaceutical industry makes a higher profit than almost any other type of industry. And you can say, well, that's very bad. But one of the things that you have to understand is that the high prices that are charged lead to high profits. But those high profits lead to high investment. And that high investment is absolutely essential for rapid progress. It's because of lots of money pouring into these profitable pharmaceutical companies. That's why the new drug development is looking like this, where the number of new drugs that are coming along that are effective is rising so rapidly. If those profits weren't there, this progress would not be there. So it's a simple trade-off that's absolutely essential. And also, again, if any of you receive any payment from the Canada Pension Plan, you have to understand that your pension plan does invest in these pharmaceutical companies, and that's where some of our income after retirement comes from. So we need solutions to high prices that do not completely gut the profits, that drive investment and drive progress. So there are two major camps when it comes to solutions. One is government price controls, and the other is restoring market forces. But there's a big problem with government price controls. These almost always fail. There's a long history of this. If any of you remember back in the 1970s with wage and price control, they were an abject failure. And economists will tell you why they failed, because they lead to shortages, and they also lead to end runs and special considerations that eventually drive prices up rather than down. So government price controls have been proven to not work very effectively. And then there's restoring market forces. And in chapter 13, we discuss a number of things that need to be done to do this. But from my take, the single most important thing is we must start by drastically reducing the cost of new drug development, because there's a huge amount of waste here, a huge amount of things that don't have to be done the way they are, but drastically drive up costs. So if we bring down the cost of new drug development, this would give room to cut prices without eradicating the profits that drive investment and progress. And also this would increase competition because then small companies could play too. And this would increase competition. That would have a direct positive effect on bringing down prices. Okay, chapter 14 is ours is better than yours. And you've all heard Americans say that about their healthcare system. Canadians say that about ours. And the bottom line, both have major strong points, both have major problems. So the United States has the most expensive healthcare system in the world. But despite that, their average life expectancy ranks 46th in the world. They're just ahead of Albania. And the reason for this is that once you turn 65 and get US Medicare, that is gold plated. You cannot beat the US Medicare insurance system. But if you're under the age of 65, you don't have that. If you don't have private insurance, then you're in trouble. And and this is where the problem, if a young person dies of something preventable, has a major impact on your average life expectancy. And for example, the United States has one of the highest maternal death rates and one of the highest infant death rates in the Western world because of underinsurance of young people. Then there's also another number of things outside the medical system also that impact this. So that kill people that don't have anything directly to do with the healthcare system. So that deaths from traffic accidents are much higher in the United States and Canada. Drug overdoses, again, per million population, substantially higher in the United States and in Canada. Homicide rate, you're 5 times more likely to be murdered in the United States than in Canada. And then you're also 6 times more likely to go into prison if you're in the United States in the land of the free than in Canada. And if you go to prison, that takes an average of 5 years off your life expectancy by going to prison. So if we look at Canada, Canada has the 11th most expensive healthcare system in the world. So in 1985 to 1995, we ranked 7th in average life expectancy internationally. But by 2020, we'd fallen progressively over the years. So we're down to 16th by 2020, and it's projected that we will fall to 27th by 2040. And the reason for this is that we've got a major problem with access to many things. So we've got much longer wait times to access things that are important for health than in many other Western countries. So if we just look at cancer, the 5-year probability of surviving cancer, if you're an American, is 67%. If you're a white American, 68%. If you're an African American, 63%. Here's what it is in Canada. So we have the same probability of surviving cancer as an underserved African American population. So if you look at it by income, the poorest Canadians do better than the poorest Americans. So that's good. But on the other hand, the top 4/5 of the population with respect to income do better in the United States than they do in Canada. And so that's bad for Canadians. So if the average Canadian had the same access to rapid diagnosis and treatment as the average American, about 9,000 of the 84,600 Canadians who died of cancer in 2021 might have survived it. So, as far as just drug access, the things that impact it. So we've already talked about drug development, time in clinical trials. And then if there's a new drug that comes along, so when will a company apply to sell it in your country? And they'll do this first in countries that are willing to pay a lot and very large markets, because they have to recoup the cost of drug development. So they're going to try to go where they'll make the most profit to try to recoup these costs. And also then there's the important thing, how long will it take for an individual country's review process to review it after they do submit it? How long will it take them to launch the drug? So after Health Canada or FDA approves it, how long will it take them to actually get that drug onto the market? And then very important in Canada, how long does it take for a country to start paying for the drug? So either OHIP in Ontario or the BC government or the Alberta government, how long does it take them to start paying for it? And also, before you start getting these drugs, you need to have a diagnosis. So you need to undergo the diagnostic testing and the staging testing before you can even start these therapies. So as far as the amount that a country is willing to pay, historically, Canada has been willing to pay more than many other countries. So in this just everything, all the other countries relative to Canada. If Canada is set at 1.0 for the price, how much do other countries pay on average? So the Americans pay about 3.5 times as much for every drug as Canada does. So they're massively outliers here, and there are very specific reasons for that. Whereas on the other end, Turkey only pays 30% the amount that we do for new drugs. And most of the drugs are not too far off where Canada is, but many of them are a bit below Canada. So because of the amount that we pay, the companies will on average apply to Health Canada before many other countries. So they apply first to the United States on average, then they apply to the European Medicine Agency, then to Canada. So this is determined by market size and how much countries are willing to pay. So the US market, so it takes the FDA 10.6 months to review the drug once they apply there. They have 330 million people, and they've got the world's highest drug prices. So every company wants to apply the United States first. Then there's the European Medicine Agency. They take about 12 months to review it. So a little bit longer than the United States, but not much. And they're reviewing for 500 million people, and some of their countries pay very high prices. And then they pass it on to Canada, where again, the Health Canada is not too badly, a little bit longer than the FDA, but not too bad. But we've only got 35 million people, but we have typically in the past paid high prices, and this is why they've come to Canada. Although with recent moves to reduce prices in Canada, we're seeing that access is starting to become a problem. So overall, Health Canada, if they apply to Health Canada, we have the fourth fastest approval, and once it's approved by Health Canada, then if you can afford to pay for the drug out of pocket, you can buy it. Or if you've got good drug insurance, then you can buy it. But this does not come with public funding. So if you're relying on the Ontario government or the BC government or the Alberta government to pay for it for you, this is going to take quite a bit longer for that to happen. So that's how fast the companies will apply to Canada if they're going to apply at all. But in fact, many drugs, they don't even apply at all because the market is relatively small. So only about 2/3 of all the drugs that were launched globally in the last 20 years were launched in Canada at all. So here we are. This shows that the time to Health Canada approval and launch in Canada compared to other regulatory agents. And so Health Canada does not too bad. So 1 year longer to get it approved in Canada compared to the FDA in the United States. So that's a year that's important, but at least it's only a year. The huge problem comes with public funding. That takes another 1.5 years longer after the Health Canada approves it on average, and that time is getting longer. So that we take more than 400 days longer than the OECD median. So OECD is the Organization for Economic Cooperation and Development, the group of the 38 richest countries in the world, and we take much longer to get public funding than other countries. So we do marginally better than New Zealand and Portugal, hooray for us, but we do much worse than most European countries and countries like Korea and Australia and countries like that. So if we then look at it from the proportion of new cancer drugs that were launched between 2011 to 2020, as far as getting public reimbursement, we ranked 14th out of 19 the countries looked at. So 14th out of 19th, that's a pretty dismal record. So yeah, we beat Portugal and Czech Republic and Slovak Republic, but I mean, we should not feel proud just because we did that. There's a whole bunch of other countries that got their citizens much faster access to these new drugs, cancer drugs, than Canada did. So as far as the public funding, it depends on a country negotiating a price with a company. And this just shows the relationship between the price a country is willing to pay and the days to public funding. So the 30th rank, that's the highest price. So the US pays the most, and they get the shortest time to the US Medicare funding the new drug. And the more countries will pay, then the faster they get. But there are two outliers from this graph. But if we include those outliers, here's Canada and New Zealand. Despite Canada paying a lot, we have very poor access from the point of view of public funding. And so this says to me that there's a fundamental problem with Canada's approach to negotiating public funding for our drugs. And this is incredibly important because these drugs, these cancer drugs, they can meaningfully prolong life and alleviate suffering. So this is from a paper that we published a couple of years ago, showing at the losses in Canada because of how long it takes to get public funding for these new drugs. So thousands of Canadians may suffer unnecessarily because they cannot get access to drugs that could have alleviated their symptoms. and thousands of Canadian life years may be lost due to these delays in public funding. Again, it's fine you got private insurance and can get access, or if you're very wealthy, but if you're relying on public funding for these drugs, then we're in deep trouble. So why does public funding take so long? And I say it's because of a highly dysfunctional system to do it. So after Health Canada approves a drug and you can access the drug if you've got private insurance, then the drug gets passed on for health technology assessment to the Canadian Agency for Drugs and Technologies, or CADTH. And it takes an average of about 6 months or so to evaluate the drug. And then it'll either approve it or not. But if it approves it, then it will say the drug is approved, provided the price that is charged for it comes down to $50,000 per quality adjusted life year gained. So that means that the drug prolongs life expectancy by a year, and it's a high quality year of life. So no cancer symptoms, or few cancer symptoms, or very few side effects from the treatment. So it's not just prolonging life expectancy, but high quality. And one can say, okay, well, might be reasonable. I'll show you in a few minutes why it's not reasonable. Then once the CADTH approves it, then it's passed on to another group called the Pan-Canadian Pharmaceutical Alliance, and they negotiate prices with the company, and they'll take CADTH's recommendation, and then they'll negotiate. So they may not hold to CADTH, but they'll try to get it down as low as they can. And then after the PCPA approves it, then it's passed on to provinces for further negotiation. So between 2013 to 2015, it took an average of, again, 529 days, or a year and a half, from the time Health Canada approved the drug until it got funded by most of the provinces. But by 2016 to 2017, this had increased to 1.8 years. So as far as what's taking up the time, so it took about almost 2 months from the time that Health Canada approved it until it goes to CADTH. It then took CADTH another 7 months for them to do their evaluation. Then 5 months before PCPA will even look at the drug, and then another 7.5 months for PCPA to do its negotiation, and then it gets passed on to the provinces. So 1.8 years, and that time is lengthening. So here, now the interesting thing is, again, you've got insurance that you can get it right after Health Canada approves it. So all those people, or most of the people that work for CADTH and PCPA, they have private drug insurance because they belong to the federal government or a provincial government. And so they got private insurance that comes as a result of them belonging to one of these government bodies, and they can get it right away right after Health Canada is approved. But the rest of us that they're negotiating for on our behalf, we have to wait for until this long afterwards. So if we look at what CADTH demands for price reductions, so the drugs that were approved between 2020 and 2021, so remember, it's costing an average of more than $2.9 billion to get these drugs approved. And CADTH says that the prices that the company asked, that they have to come down by more than 50% for the overwhelming majority of these drugs. And again, they use this threshold of $50,000 per quality adjusted life years. But there's a big problem in measuring qualities. Is a very inaccurate measurement, and I go through in the book why this is a problem, even using this as a measurement. And then the other thing is that $50,000 per quality, that's exactly the same level as in 1975. At 2025, $2 is worth 5 times the amount, or 5 times less than a $1975. So essentially, what's happened is that the CADTH has devalued Canadian life by 80% compared to 1975. So, and this is what happens if the more that CADTH says that the price has to come down, it lengthens the time until while the provinces negotiate, or while PCPA negotiates. So it delays access to these public drugs. So why is this happening? Well, in 2015, the Liberals promised in the election then, they promised Canadians lower drug prices. And many of us thought this would be a good idea. But I personally didn't understand that the cost of lower prices would be reduced access to effective therapies. So that's what you have to give up to. If you want lower prices, you get to reduced access. So this gold bar in the middle of these, the gold part in the middle of these bars is drugs that CADTH demanded major price reductions. And starting in 2019, the proportion that demanded major price reductions went way up in keeping with what the government had promised Canadians. So, and the provincial government funding cannot move faster than federal level institutions like CADIF and PCPA. So at a recent meeting, one of the PCPA members said to one of my colleagues during coffee break, so why are you oncologists always in such a rush? Why do you want these drugs approved so rapidly? Well, we're in such a rush because we're trying desperately to alleviate our patients' suffering and save their lives. But CADIF and PCPA, they just don't seem to get that. In my opinion, this is a problem, a major problem with leadership. So this is not some sort of conspiracy that they're trying to keep drugs from us or anything like that. It's just that they don't care, that they've prioritized price over access. Then added to this is the other part of the Canadian system, the Patent and Medicine Price Review Board, which is a second system that looks at cost. So it's a second player in regulating prices in Canada. So it sets a maximum price that a company can charge for a drug. And in 2017, the PMPRB proposed new regulations to reduce drug prices. And they mandated an initial price reduction of 20%. So we want a fire sale. We want Boxing Day prices for our drugs. Well, if you wait for the Boxing Day, you might be able to do that. But a lot of patients are going to die between now and Boxing Day if you can't get access to the drug. And then as sales increase, they wanted further marked reductions if the company actually was successful in selling the drug, so that some drugs, that the price reduction would be 80% or more. So if you were trying to sell something and somebody said, well, buy it as long as you cut the price by 80%, you might think twice about wanting to sell to that buyer. And in 2020, when the PMPRB gave public hearings on why their approach was so important, one of the things that they pointed out was how patented medicines, the price of patented medicines was escalating rapidly. And just see this massive escalation in prices in cost between 2013 and 2017. They convinced a lot of people this is pretty alarming. But here's what their 2020 annual report. So the price in 2020 of patent medicines as a proportion of GDP was lower than in 2002. It was the lowest it's been since 2002. And 2017 was the highest subsequent one. So they intentionally cherry-picked the times as the highest and the lowest points since 2002. And so that 2019 was actually lower than it was in 2002. So the way that the PMPRB presented this, I personally thought was intentionally misleading. In that same presentation, they pointed out that they said, will lower prices result in fewer drug launches in Canada? And they point out that countries with lower patented drug prices in Canada may have greater availability of new medicines. And they showed these data to support that. So the intent of this was to appear to make the point that reducing Canadian prices would not negatively impact drug access. And I would say that this is wishful thinking because they certainly did not analyze their own data very well. So I just took their data and replotted like this. So the left panel is the relative price a country will pay versus the proportion of new drugs that are available. Very strong correlation. The higher the price a country is willing to pay, the higher the proportion of the new drugs, effective new drugs, that the country will get access to. And here it is for drugs for countries that are not European members. Same thing. The higher that a company pays, the higher the proportion of drugs that they have access to. When I did the analysis based on this, my calculation was that if we just went with a PMPRB reduction of 20% of the prices, even without the increased costs after if the company is selling very many, that would decrease Canada from having access to about 48% of drugs that are launched elsewhere down to no more than 40%. So again, Canadians would be missing access to effective new drugs that could alleviate suffering and save lives. So Canada's huge error was that CADIF and PMPRB are trying to force down prices while ignoring access. This will worsen Canada's already impaired access because if the prices are very low, then companies will not even apply to Health Canada to get their drug approved. So even people with insurance are not going to be able to get access to it because the drugs will not be approved by Health Canada. And also it means a much longer time to provincial funding of these drugs. So we instead need to concentrate on improving access while looking at innovative approaches to cost control. So the other thing that's important is how long does it take for diagnosis and treatment? Because you need for these things to happen before you can get access to the drug. So you'll need to have a CAT scan done before you can get your diagnosis of cancer. Here's where Canada ranked with respect to the other OECD countries, the other Organization for Economic Cooperation and Development countries. So in 2017 to 2020, Canada ranked 30th out of 33 in access to CAT scanners per million population. So behind Turkey and Greece and Chile and all the Eastern European countries. So if you think it takes a long time to get a CAT scan, here's a reason it takes you a long time to get a CAT scan. You wouldn't be waiting that long if you lived in most other countries. Here's an MRI scanner, 26 out of 31 for among OECD countries. Here it is for hospital beds, 30 out of 37. You wonder why so many elderly Canadians died of COVID in those horrible nursing homes? The answer is very simple, because there was no hospital beds to transfer them to. Here it is for radiotherapy machines, ranking 27th out of 29 among OECD countries. Here it is for medical specialists, ranking 31st out of 34. We think we got a problem with family doctors. There, at least we rank just about between the top third and the middle third, right at that boundary. We're much, much, much worse in access to specialists. So if there's a delay because you can't access scans and specialists and biopsies and all those other things, what's the impact? So if you've got an early stage cancer that could be cured, that may directly translate into an increased risk of dying from that cancer because it is not being dealt with fast. And so breast cancer, lung cancer, pancreas, and kidney cancer is 1% or more increase in mortality rates per week of delay in getting the cancer diagnosed and therapy started for early stage disease. If you've got metastatic lung cancer, so metastatic non-small cell lung cancer, so these patients are falling off the cliff. They're getting a lot worse very rapidly. So what happens is that for every week of delay in initiating chemotherapy for these patients, 4% of remaining patients die for every week of delay in starting treatment. And many of the people that they might survive that week, but many of them will become too sick in that week to even consider starting treatment. I see this every day in my clinic. Patients I see, I do everything I can to get them on treatment rapidly, but in a week or two it gets to get the other necessary things done, they become too sick and they cannot undergo treatment because it does take weeks to get many of these things done. This is the reason that despite the fact that treatment for metastatic lung cancer is funded in Canada, only 25% of patients with metastatic non-small cell lung cancer ever make it to treatment because it takes too long to get them there. So here's the probability of surviving cancer if you get it. So this is the different ways of measuring this. This one I've put up the mortality to incidence ratio, the number of people diagnosed versus the number of people dying. And so Canada, you look at Canada versus United States, and again, so this does not look like a huge difference there in the probability of surviving it. But again, if the average Canadian had the same access to rapid diagnosis and treatment as the average American, but that would translate to about 9,000 fewer deaths than among the 84,600 Canadians who died of cancer in 2021. So what are the solutions? Well, we need to prioritize access overall, not just price. Price is important, costs are important. But if you would not prioritize buying cheaper seatbelts or smoke detectors or life jackets if the cheaper ones were completely unreliable. So why prioritize reducing drug costs and access to CAT scanners and things like that, despite this meaning that patients suffer and die due to reduced access to effective therapy? Cost is important, but we also need access. And we don't just need access for the public servants and others who have private insurance. We need access for all Canadians that are relying on the public health care system to deliver their care. So the way I see it, that this is a problem of leadership that starts at the highest political and public servant levels of the Canadian federal government. We cannot fix this unless the government says that this is important. And they are not going to fix this unless all of you notify your elected officials and tell them that you think that this is important. So again, a lot of these things are discussed in my book, as I said, that if you are interested in buying it, you can get it through my website at whycancerstillsucks.com or through Amazon Books. And any profits from the book, if I ever make any profit, I'll be sharing with a bunch of different charities, such as Life Saving Therapies Network and Lung Cancer Canada and other groups like that. Thank you.
Great, thank you so much. I'm just gonna We'll move into our Q&A here. I've got some questions in the chat. And then if anybody has any other questions, please feel free to raise your hand or send them in the chat to either me or Maya, and we'll either read out your question for you or call on you to unmute so you can ask it yourself. So we have a question here. Androgen receptor inhibitors like Enzoludamide have been shown to be effective in suppressing prostate cancer in patients who otherwise would be candidates for active surveillance. Is this any surprise? Should low-risk patients be taking these drugs? And would you consider this a pharma scam in the making?
I'm sorry, would I consider it what?
A pharma scam.
Pharma scam. So that we know that with drugs that are effective in metastatic disease, that some of them can also be very effective in earlier stages as well. That's where adjuvant treatment comes from after patients undergo surgical removal of a cancer or after a radiotherapy with curative intent, that some of these adjuvant therapies can improve cure rates or survival. So I don't, because it's been many, many years since I've treated prostate cancer, I don't know whether that drug in particular, what the data are, but whether or not to use it, it will be important to have data. And so the companies that make these drugs, they will be actively doing the clinical trials to see whether or not the drugs are effective. And if they are, then that's a type of thing that they might apply to Health Canada to have it approved for use in that population. And then it would have to undergo the questions for public funding. So the reason the clinical trials are important is that there are many things that might make sense that we think will work that end up not working for a bunch of reasons. And for example, with things like hormonal therapies and targeted therapies, it's possible that they will just slow down recurrence rather than getting rid of recurrence and actually curing patients. And it's possible that, in fact, that if you just wait until the patient relapses and then give the treatment there, it might have exactly the same impact on life expectancy and quality of life and everything else. And so we really need to study this to be certain. An example is in lung cancer, there's a drug called osimertinib, that if a patient has an EGFR mutation, that drug is very effective at reducing symptoms and prolonging life expectancy in patients with metastatic disease. If the patient has a localized disease that is removed by surgery and they have that mutation, if you give osimertinib, it can markedly slow recurrence of the cancer. But so far, there's no real evidence that it prolongs life expectancy, just because it can also be effective when given in metastatic disease as well. And so if you treat everybody, including those who may have been cured, you may be treating a lot of people that just don't need the drug and are just going to get the side effects. So very important question. But also this is something that I mentioned in chapter 15, on the future of cancer care. In the future, we will not be giving adjuvant treatments after surgery to all patients. Instead, what we will be doing is very sensitive blood tests to see whether there's still surviving cancer cells circulating in the bloodstream. And if there are, we will know that patient is not cured and they should be treated. Whereas if there are no circulating cancer cells, that patient very well may be cured. So I'm not sure whether that answers the question or not. Was there any other aspects to that question?
No, I think that pretty much answers it. The follow-up was just, should low-risk patients be seen by medical oncologists at all?
So low risk, ordinarily not, unless the medical oncologist is going to have something concrete to offer. So again, in the future, if there's a toxic therapy that will improve the outcome, then often those more toxic therapies are best done by medical oncologists, because that's their expertise, is how to use toxic therapies in a way that is a net benefit to the patient. But for example, in lung cancer, which I see mainly lung cancer, so if a patient has stage 1 lung cancer, I only see those patients in the clinic if they are a potential candidate for a clinical trial. So for example, we're currently participating in a clinical trial of a immunotherapy to see whether it will improve outcome. So then I'll see the patient and offer participation in the clinical trial. But if they're not taking part in the clinical trial, there is no standard therapy that I could give the patient that will have been proven to be of benefit. And so they will be just as well looked after by their surgeon or or the family doctor until they do develop a cancer, and then they can see us. Now, part of the issue here is across Canada, there's only 500 or 600 medical oncologists, despite cancer accounting for 30% of all deaths in Canada. So it's a thin red line of oncologists. So if we tried to see all patients with cancer, we would very rapidly get overwhelmed. So this is compared to 1,200 cardiologists, 4,000 psychiatrists, et cetera. So that we concentrate on trying to get patients into the clinics as rapidly as we can. So in 2 weeks or less, if they need us, but it also means that there are a bunch of other things that we of necessity have to leave to other people.
Great, thank you. The next question was, excellent presentation. Is there a prostate cancer advocate within the government that we could support?
I absolutely do not know the answer to that. Within your advocacy group, so some of the people there will have the best idea who advocates are. So the advocates typically are not within government. It's important to have sympathetic people and understanding people in government and dedicated people in government. But as far as advocates, I don't know of anybody that I could actually call an advocate. Actually, in fact, there probably are. So, for example, there's one person who is not a senator but works in the Senate, who works with us very actively to try to get access to people for lung cancer because her significant other died of lung cancer. So, because cancer is so very common, a lot of people within government, they will have been touched by this personally.
Right. Thank you. Does the Canadian government demand reduced prices because they have contributed to the R&D costs?
No, what they contribute to the R&D costs is absolutely not an issue at all, because Canada actually invests less in research than many other Western countries. So our overall level of investment in research is far lower than what it should be if we're just to maintain our quality of life or standard of living. And so if you look at the investment cost to develop a new drug, so I've heard it said in the past that drug companies should not be making these profits because look at how much it was paid for by, for example, the American government through the NCI in the States. But if you think about it, to discover the drug might cost $1 million or $10 million. It rarely costs much more than that for all the stuff done in the laboratory. Most of the $2.9 billion that it takes to then bring the drug to market, those are the clinical trials costs. Those are not done by government. So that there are cooperative groups that in the United States, the government gives a little bit to the cooperative groups, but they spend much less than drug companies do. So that if the Canadian government uses that excuse, so anybody in the Canadian government who uses that excuse does not either deliberately misleading or else they don't know what they're talking about.
Fair enough. Okay. I thought I saw a hand, but I think they've disappeared on us. So we'll go to the next question in the chat. Is there a particular drug company that focuses on prostate and metastatic prostate cancer?
Yeah, so the answer is I'm sure there is. My apologies, I can't tell you which one, but if you just look at the drugs that prostate cancer patients receive and look at the company that makes them, that the reason that drug company is making that drug is because they did or they have concentrated on prostate cancer. If they make two different prostate cancer drugs, then that means that this is an area of special interest to them. But I think most of the drugs, most of the companies will start by looking at different types of therapies, not just for one cancer, but then they'll start narrowing it down depending on where they think the important advances can be made or where the profits can be made. And prostate cancer is very common, so it's an area that there's a potential for profit. So that's a good thing because that leads to more research.
Right.
Thank you. I have a question here. So will Dr. Stewart share the name of the female senator who might be supportive of improving the situation?
No, so it's actually not a senator. It's a person who lives in the office or works in the office there. And so I would not be able to share her name without her prior approval of that.
Yeah, no problem. Thank you.
I believe that's all the questions in the chat. Does anybody have anything? Oh, Mike, feel free to
so actually I have a question for you there, doctor. So you talk about, contacting our MPs or MLAs or the government, whatever. I think part of the problem is that because cancer is such a wide issue for example, I got prostate cancer, whatever. Given the size of government and the speed of government and the fact that it can often be not working as the way it should, I think would be a good word for it. Is there a specific issue that we could send to our MPs or our Minister of Health about a specific issue that would be, I guess, simple for them to get the message through? Like, we can't just say, oh, I want more funding for prostate cancer, because the message just gets lost in the shuffle. But is there something we could talk about? Like you talked about the fact for OECD, we're 30th of, 37th for drug release trials. Like, I guess what I'm trying to, I could write a letter to my MP, but I don't want to just say, oh, throw more money at healthcare or give more money to the provinces, because that doesn't really mean anything. You know what I mean?
Yeah. So a very good point. So I would say, no, don't. The problem if you say you have to spend more money on prostate cancer, and then they'll temporarily shift it to prostate cancer from somewhere else. And so, example, we had this problem for a long time with breast cancer. So when AIDS came along, breast cancer advocates said they're spending far too much on AIDS. We need to get it shifted to breast cancer. And oh, by the way, those people that got lung cancer, they did it to themselves. We with breast cancer didn't do it to ourselves, even though many of them did contribute to either by drinking alcohol or by other things. And so that it ended up that there was a vastly disproportionate amount of money, of government money that went to breast cancer because of this political initiative. So that the thing is not that the government has to spend more on research. They've got to fix what they're doing wrong. So that they've got to fix the speed bumps on the Autobahn. And so Canada by itself cannot get those fixed because it's part of an international group looking at those speed bumps. But people from Health Canada take part in monthly meetings with people from the FDA and the EMA, and so we have to make sure that our voice is that things need to happen faster, that the regulation has to be more cost effective. And then as far as the public funding, we have to shift government away from let's get the cost of medications down to let's get better access while we also work on ways to make it affordable. But this whole thing of cost has been a major problem. So in 2015, during the election there, I talked to candidates from many different parties, all of the different parties. I told them all that my number one priority was pharmacare, that I thought we needed national pharmacare because in Ontario, somebody over the age of 65 could get access to new oral therapies for cancer, but somebody under the age of 65 who was not insured could not get access. But be careful what you wish for, because it's like the story of the monkey's paw. They thought this is a good idea, and the way we're going to do it, we're just going to drive down the cost of new medications so that everybody will get free access to medications for their hemorrhoids or their acne or their heartburn, but nobody gets access anymore to medications for cancer because the companies are no longer going to sell them to Canadians, or they're going to say that Canada waits for the Boxing Day sale years after they've been available in other countries when thousands upon thousands of Canadians have already died. So it's all about the government has to reset its priorities. They have to look at all the things that they've got wrong. And I completely agree that just spending more money is not the answer. But just as an example, the Liberal government in Ontario under Wynne, so that they said we're going to be kinder to nurses. We're going to give them all a 2% per year raise, so that this will keep them happy. But then they said to the hospitals, but we're not giving the hospital any increase in their budget. So they effectively gave all the hospitals a 2% per year cut in their budget. At the same time, all their other costs were going up. So this led to predictable outcomes that things just did not work. Then the Conservatives came along, they said, well, we're going to cap everybody at just a 1% per year raise, and then same predictable thing. then everybody got unhappy, and thousands of nurses left the workforce because they felt underprivileged. Governments just have to stop doing stupid things, and because that's what they're doing right now. They're just doing stupid things, so the provinces, they are responsible for a lot of the healthcare. That they get the dollars from the federal government. If the federal government does not produce it, they give them the dollars, or does other things that increase their costs, then this is a problem. In some ways, it might be better if the provinces just acted independently in health, and then at least some of them might be able to do a good job of doing it, instead of them all being constrained by the same system that actually slows them down. So you just tell your MP you want them to do better, not that you want more prostate cancer research or breast cancer research or access to a predictive drug. You want better access to healthcare. Period.
Okay. All right. Yeah, I can figure that out. Yeah, because you can't just, it's elevator pitch, right? You can't just say, "Well, I want everything." You gotta be specific, right? A specific goal, right? So
yeah.
Okay. Thank you very much. That helps.
And there are ways to do this. So in our hospital, Dr. Michael Funkyfong is a world expert on transformation. So we took our lung cancer problem and we actually looked at all the things that delay things, and got dozens of people together once a week for a year, from radiology to pathology to surgery, nurses, everybody, getting them together in a room to look at where all the choke points where things slowing down, and without raising costs, how can we get rid of those choke points? And so that's what we really need. In fact, that's the only reason that Canada does not do far worse than it does without access to CAT scans and MRI scanners, is because our CAT scanners are some of the most efficient in the world. They'll work 24 hours a day in some hospitals, but as soon as one goes down, then you've lost your backup. Then you're in deep trouble, and we just do not have nearly enough of them for the proper backup. So the governments just have to get much smarter than they have been, because they have just been doing things in a very unthoughtful way.
Okay, thank you very much. That helps. It does. Yeah.
Thank you. I have a question here. Any suggestions on how we can raise the profile of prostate cancer similar to what breast cancer has done?
Yeah, so I'll tell you what the breast cancer people did in the United States. Back in the early days of breast cancer activism, they would get all the breast cancer activists around, and they would go to places where there were going to be politicians, and they'd back them into a washroom and not let them out of the washroom unless they promised to fund things more. So it's more like breast cancer terrorism than anything else. And as I said, they were very effective at increasing the funding for breast cancer, but that has not helped cancer overall. And again, prostate cancer might be able to do that, but again, your brother or sister with lung cancer or colon cancer will be paying the price for that unless we move everybody together at the same time. This has to be about everybody moving together at the same time. Now, the other thing I'll point out that Louise Binder is a very well-known cancer activist, but before she was a cancer activist, she was an AIDS activist. So she developed AIDS 20 years ago, 20-some years ago, and become an activist. And what she pointed out was a big problem with cancer patients is that unlike AIDS patients, cancer patients are far too polite. They will sit back and they'll be polite, and that has a major problem. Like the AIDS people, they weren't being polite to anybody. They were angry. They had been disenfranchised, so they were very angry, and that's what moved people forward. With COVID, everybody was scared, and that moved people ahead. The problem is that cancer is so common, so diffuse, and the other big problem with cancer is that nobody can believe that things are as bad as they are until they get it. They don't believe that they can't get access to effective new drugs that most other patients in the Western world would be able to access. So they just can't believe that this would be bad, and that's also partly diluted by the fact that if you do have insurance, then you can get it. So it's not all Canadians that have it, but also it tends to be maybe wealthier Canadians, higher socioeconomic group. They're more likely to have the insurance, and they're also the ones that may also have the education to really help to further the fight more than somebody that has much less resources and might have a much lower probability of helping move things forward. So this is about all cancer patients banding together, all Canadians banding together, and insisting that that we do better. So in the book, in chapter 14, I asked the question: so which is better, the Canadian system or the American system? And my answer is that I love them both and I hate them both. The Americans pay far too much for what they get, and Canadians only get what they pay for. That in the United States, the problem is that all the underinsured young people and the minorities and the poor in Canadians is older people. Because older people do not get the access they need, because the healthcare system needs to look after older people, and the older you are, the more you get, and it's just not there. You just wait and wait and wait for things to happen. So that you'll wait months before COVID, you waited months for a hip replacement, and that slows you down. That makes you, if you can't walk properly, you can't keep your cardiorespiratory system properly. So that's bad for your overall health. If you cannot get the things like joint replacements and other things like that, that can help help you stay healthy in other ways. And also, I point out as well that every country is they're sort of prisoners of their own ideology. So in the United States, their ideology is that the land of the free, despite them having the highest imprisonment rate in the world. In Canada, it was the ideology that that we had the best healthcare system in the world, despite the fact that all the data showed very clearly that was not the case. But we're trapped with that ideology until we can fully grasp the fact, as a population, that we've got a huge amount of work to do, and we can do it. We just have a huge amount of work to do, but we have to understand that that's reality, and we need to fix the things that are broken.
Thank you, Dr. Stewart. I have a question here. Why do U.S. urologists support DNA and genomic testing while their Canadian counterparts don't?
So support what?
Genomic testing.
Okay, so in fact, actually, it's interesting that if there's a treatment that is specifically tied to a genomic test, many places in Canada actually do it well. So that in Ontario now, for example, in lung cancer, adenocarcinoma of the lung, there are now several different drugs that will work with one very specific mutation. So now it's now set up that our pathologists will automatically start doing that genetic testing if there's a drug there. Actually, the fascinating thing is that Canadians now have better access to genetic testing like that than many Americans do, because in the U.S. system, it's all of these different pathology labs. Some may offer it, some may not. If the patient goes to one oncologist, they may be working with a lab that they can get it, another one will not. And also the importance of speed, so that genetic testing, whether it's in the U.S. or Canada, slows things down. And so that in fact, where genetic testing is important, then it's strongly supported. There are a number of other malignancies where it's not important. So adenocarcinoma of the lung that I treat, very, very important. Small cell lung cancer and squamous cell lung cancer, it has nothing because there's no treatment that we can tie to that. So that even with many of the targeted therapies, there's not yet a target and not yet a mutation that we can link that to. Like an example is immunotherapy, that we know if there's high PD-L1 expression, that immunotherapy is going to work better. But there are some people that have no expression of PD-L1, it will work great. Some people with very high expression doesn't work at all. So it's a very bad marker. So that the important thing in all instances is to see whether we can define markers that are important. But if we do, then Canadian government may, or the provincial governments may move fast to adopt it. Although again, if they decide not to move, everybody can be stuck in the same place, and so you'll get different things. Like in the United States, if you happen to go to Sloan Kettering or to Dana-Farber, you'd get a wealth of genetic testing very rapidly. If you went to the average community oncologist in the United States, you just would not get that. So there's more uniformity of approaches in Canada, but some of them are better than the United States. Some of them are slower. Again, that's why in chapter 14, I say that I love them both and I hate them both. They both have major problems, and neither of them has it quite right yet.
Thank you, Dr. Stewart. And then another question, how long is the wait time for an MRI in Canada?
So it depends what it is. So it depends where you are and what it's for. So here in Ottawa, and I'm not sure it's across Canada as well, but if you come into the emergency room and it looks like you've broken your neck or something like that, and you need an emergency MRI, you get it right away. If it's something that is, so that's called a P1. So the P1, P2, P3, P4. P2 is something that is very urgent. So it looks like you might be having a bleed into your brain, a slow one. Then you'll get it done within 48 hours. P3, which is cancer, they try to get it done within 2 weeks, but it may take longer than that. If it's P4, so you got a bad knee and you want to get your knee, an MRI on your knee, you may be waiting for a year or two if you get it done at all. And in fact, our radiologists have said that they've even just stopped looking at the P4s. They've just given up. It's hopeless. And the same thing with CAT scans, P1, P2, P3, P4. So that, for example, for following our patients with cancer, so CAT scans are very important to tell us whether the cancer is getting bigger or smaller. If it's getting bigger, we don't want to carry on the same treatment that is not working. We want to get the patient changed to something else, or at least stop something that's potentially toxic. But if I have a patient that I need to get a CAT scan done in a certain number of weeks to tell that, then sometimes I may get it done with the number of weeks that I need. Sometimes so I have patients that they get on the waiting list and they call the hospital and they say, well, call us back in 6 months. Sorry, we have no room at all. So this is again a huge problem that when the system is so stressed that even in the situations where the scans are unequivocally needed and are unequivocally of value, we cannot get them done because either we can't get the patient started on treatment to start with, or else if we got them on treatment, the question, do we carry on or not, where the treatment is very expensive and particularly very toxic. And if it's not helping the patient, you do not want to do this to them. If you're giving them the possibility of a life-threatening or fatal complication, if it's not helping them. And so this is a huge problem that we do not have adequate access to radiology testing, and even pathologists. I mean, our pathologists they work as hard as we can, but between the 1990s and a couple of years ago, the number of pathologists in Canada per million population dropped by about 43%. So these are the people that have to look at the pathology slides, come up with a diagnosis, and then they have to do all this molecular testing. So there's far more that they have to do now with the molecular testing than they had to do before. And yet there's a decrease in number, again, in keeping with this big problem that we've got in specialists overall. And actually, one of the problems that we've got with family doctors is in other countries, family doctors are much better supported by specialists than they are here. Here, not enough specialists, so the family doctor ends up shouldering more of the load, and that means that they have to cut down to lower numbers of patients because they just can't handle the same load if they do not have the same backup. And also, there's a major funding problem with funding of family doctors. That's actually a major part of why there's a shortage of family doctors. So if a family doctor sees a patient in their office, they're paying 30 to 40% overhead. Whereas if they go and work in a hospital, or if they work in an operating room, or do other things like that, they pay no overhead. They get paid the same amount, they pay no overhead, so they get a 30 or 40% raise, but just by not seeing patients in their office.
Okay, thank you very much. So I don't see any more questions, but if anyone has any, feel free to raise your hand, or you can unmute yourself, put them in the chat.
I've actually got one here in the chat, and then we'll go to you, Richard. I just got, is PSMA PET scan, are PSMA PET scans available in Canada, and what would the rollout timing be?
Sorry, what kind of PET scan?
PSMA PET.
So the short answer is I don't know whether it is or not. To put it in perspective, when I moved down to MD Anderson Hospital in Houston in 2003, my second move down there, after my move down there in 1976, at that time, MD Anderson had 5 PET scanners, while there were 3 PET scanners in all of Canada combined. So Canada is now doing better, but we ranked 20th out of 30 for PET scanners. The other big problem with PET scanners is that they rely on radionuclides that may have a very short half-life. So you may have to produce the radionuclide very close to where the scan is provided, because it'll just decay too fast if you have to ship it for long distances. And the cyclotron to make those radionuclides are incredibly expensive. So this is another problem that Canada has with healthcare overall, is that a small population spread out over very long distances. So if you're in a country like the United Kingdom, where everything's close together, you have 50 or 60 million people, they're all close together, it's far easier to set up things centralized. Much more difficult to do that in Canada and try to serve the entire population. So that I know for most PET scans that it's only the standard ones, the fluorodeoxyglucose ones that we can get. So there will be some that are being done as a research tool in other places. And so it will depend on how active, how much benefit they actually appear to be. And then after it's been shown unequivocally to be beneficial, then it will still take Canada too long to move to it. But I'm not aware of it being at the point that it can actually translate into lives saved, although it may now, or there may be a time in the future that will, but I'm not aware of that right now.
Yeah, I think just to add to that, I think Joe, who asked the question, as far as I understand, PSMA PET scans are available for clinical trials right now with lutetium-177, but only through clinical trials, aside from at 2 private centers, so one in BC and one in Ontario, that offer the scan at their private clinics, but for I think like $3,000 or something out of pocket.
Yeah, so having things available as clinical trials, that's actually good if you can get it, but then it takes us far too long to set up clinical trials, and they're much too cumbersome because of all those speed bumps on the Autobahn that I talked about. As far as the charge of $3,000 out of pocket, actually one of the things that's interesting is just the difference in mindset between Canadians and Americans. So that when I was down in Houston, their patients expected to pay a lot for things. Came back to Canada, and even if it's just a relatively small amount, Canadians balk at that. But at least many Canadians do, and it's because it's just part of our mindset. But if it was very important, then some Canadians who had the resources probably would pay for those things, but their physician would have to tell them that it was in their best interest to do it. I mean, people just look at things in different ways. Like here I am in Ottawa, and we've got 2 cancer centers, one in the west end of town, the other one in the east end of town. They're 15 minutes apart. Patients are very reluctant to come across town to the one in the east end because it's too much traveling. When I worked down at MD Anderson Hospital in Houston, that I'd see people that every 3 weeks they were driving 10 hours from Kansas City down to see every 3 weeks, 10 hours each way. And it's just the way that different mindsets, not that one's right or one's wrong, but that it does impact how healthcare rolls out and how it's delivered.
Makes sense. Richard, you had a question.
Just a quick one. Excellent presentation, Dr. Stewart. Very much appreciated. The question is, in terms of clinical trials, from your perspective, are they on the rise for clinical trials with related to prostate cancer? Are they on the rise, or have they started to plateau?
So I can't answer that specifically with respect to prostate cancer. Typically, the number of clinical trials will increase and decrease as new therapies become available to be tested. If there's nothing that looks like it could be a game changer, then it's less likely to that clinical trials will be launched. But there are always lots of clinical trials. Like here in Ottawa, in the Cancer Center, overall across tumor types, we've got about 80 active clinical trials at any one time. But many of them will open for a few weeks or a few months and then close. And so the total number of studies that are activated during the year may be higher than that. So that if there are new drugs, that if there's a new indication, very importantly, most of the clinical trials are driven by drug companies. They're the ones that pay the huge amounts to run the clinical trials. If they think that they can make money by doing it, then they'll do it. if you rely on other agencies like CCTG, which is a cooperative group that's funded by grants to do it, the number of studies that can be done is much lower. And part of the problem is just the sheer cost of doing the clinical trials. It now, for a phase 3 study for a drug company to put one patient on a clinical trial can now cost them anywhere from $30,000 to $80,000 per patient to put on a trial. And that's just to comply with the regulation to get that patient on the study and to keep it on the study and to make sure that they're not going to run into problems because of some way that they messed up the paperwork.
Thank you.
Thank you, Dr. Stewart. So just asking one more time if there are any more questions. Again, you can use the chat or you can raise your hand and mute yourself, whichever way you please. No?
Can we share the website one more time, where Dr. Stewart's website to purchase the book?
Yes.
Yeah, so actually it's simple. It's whycancerstillsucks.com, all one word. Or you can go Amazon Books. You can also do it through Amazon Books as well. Or in fact, there's a lot of different, like Barnes and Noble, Indigo. They all you can at least order the Kindle version from them or the Kobo version. But for the print version, through the website or through Amazon Books.
Yes, and Rochelle has put it in the chat, so if anyone wants to see it, they can just click on the link there. But yeah, if there are no more questions, I think then we can end this. Thank you, Dr. Stewart, for your time today. And do you have anything to say? Sorry.
Yeah, so again, thank you for the opportunity to talk. To me, this is about getting the message out. That's the reason that I'm giving a free copy of the book to all my patients to get the message out.
Yes, thank you so much. We really appreciate it.
Okay, bye.
Yeah.
Thank you.
Thank you.